Good evening, everyone. I'd like to thank you for all joining us for our last ANZ Virtual Venous Forum tonight. This is the culmination of a series of about 5 presentations of sessions that we've had discussing about venous pathology, venous treatment, and there's been very entertaining at times and very illuminating. We've had some extremely good presenters, but I've got to tell you, I think we're going to top it all off tonight with our 3 presenters, which are going to be Jerry O'Sullivan from Ireland, Rick de Graaf from Germany, and Stephen Black from the UK.
Hello.
Jerry's going to talk to us about his loop-to-loop and pelvic vein embolization. Rick's going to talk to us about renal vein, IVUS, and stenting. And Steve's going to top it all off with optimization about outcomes of DVT treatment. And then along the way, of course, we've got all of you to ask lots and lots of questions. At the bottom of your screen, you'll see a Q&A input where you can type in all your questions and we'll hope to answer them along the way. If not, we will answer them at the end. So I think we should just kick off with Dr. Jerry O'Sullivan with his presentation. I'll just stop presenting and ask Jerry to take over if he would. Oh, by the way, our co-presenter tonight is Dr. Jonathan Langton from the Gold Coast. So not to forget about Jonathan, he's been a co-moderator for a couple of sessions and presented himself with some very excellent topics. So there's lots of people to talk to tonight. So I'll hand over to, we've got Steve on the line, but I think we were going to start off with Jerry. Is that right?
We are indeed, but Jerry seems to have suddenly turned off his brain and forgotten how to do the computer because I'm an idiot.
You can only turn off what you have, Jerry.
What's that, big guy?
You can only turn off what you have.
That is very harsh. It's very accurate, but very harsh. I've somehow managed to lose the damn thing. I'm such a moron. Okay. What the hell did I just do? Okay, there it is. It
Are you the Joe Biden of the venous world?
I've already left the meeting. Return to the meeting. I knew there was. I was just checking to see. I was in there all the time. Yeah, it's kind of like a lot of my venous cases. It's one cluster thing after another, and then eventually I blunder to a conclusion. Okay, right. Hooray, we did it. Such a master of technology. Okay, loop the loop. Okay. I started doing pelvic vein embolization only about 8 or 9 years ago. I went to Cersei in Lisbon, I think it was that year. And I met a friend of mine that I hadn't seen in 20 years, 25 years, Tony Lopez from Guildford. We were chatting about what he was doing, what I was doing, and he said, "Oh yeah, I've done a fair bit of pelvic vein embolization." And I'd never done one. I've heard about it, but I'd never done one. And I said, "Oh yeah, how many have you done?" He said, "Yeah, about 2,000." And I'm like, "Oh, okay. So I got to come and see you." So, so really, this is all about Tony Lopez because he has done more than anybody else. He's amazing. Unfortunately, I don't think he's doing much of it anymore, which is kind of sad because all of that knowledge. But this is a real must-read article. It's not new, but it's very, very good. So I suppose if there aren't that many people doing pelvic vein embolization, you end up getting a lot of patients, and they fall into a few different categories for me. The majority are probably pelvic varices symptom related, and they're referred typically by gynecologists or maybe urologists or maybe vascular surgeons or some of my radiology colleagues. And they have the typical pelvic pressure, dyspareunia. Frequency of micturition is really common, much more common than people realize, and particularly at night when the varices seem to feel like worms on the patient's bladder. It must be very uncomfortable. Then there's a second group who are those with upper thigh varices or pudendal varices, less commonly, extended vein of Giacomini's, that kind of thing. They tend to be people who've typically undergone surgical therapy, or they've come back quickly after surgical therapy. And probably they're the ones that are growing faster once people realize that you shouldn't be treating varicose veins 2, 3, 4 times in a row and them keep coming back and you have done a good job the first time. It usually means that you're missing something. And in females, it's coming from this pelvis, and that's about it. occasionally you get a combination, and then the association with left common iliac vein stenosis is more common than people think, and I think you need intravascular ultrasound for the evaluation of that. So when I went to see Tony Lopez, he was attached to a guy called Mark Whiteley in Guildford, who is he's sort of devoted his life to venous, really. He's a vascular surgeon. He's got an amazing setup in Guildford, and he's syndicated across the UK now. He had, or still has, a woman and a couple of different sonographers, and they're amazing. They're really amazing. They're the best transvaginal ultrasonographers I've ever seen, because they combine TV ultrasound and really good Doppler. Now, I do quite a lot of Doppler. I don't really do much transvaginal ultrasound, but to combine the two at the level of expertise that these people have is extraordinary. And I looked over Judy Holstock's shoulder for 2 cases, and I came away thinking, boy, that is a huge advantage, because she was able to write on a chart which of the veins were refluxing. And then Tony Lopez, she would physically go down LOV, ROV, RRIV, left internal iliac vein, and so on. And she'd tick which of them he needed to treat. So he'd get the sheet of paper, and all it was like, oh, okay, I got to do 3 today. That was it. So there was no searching, there was no looking. They didn't do any other imaging at all. No MRV, no CTV at all. In reality, I've tried it hard and failed to get anybody in my unit to do it to that level of expertise. It's time consuming. It's obviously somewhat invasive. I just haven't managed. So I've ended up doing MRV and CTV, and then adding in my own ultrasound. Okay. And if you get a chance to read, this is the definitive paper here. I think it's from the Whiteley group with Tony Lopez and Judy Holstock in there. And then obviously I've already mentioned Tony's paper there. And there's other papers there that are worth reading. And I think this session is being recorded, so you can check it out afterwards. Essentially, you get pictures transvaginal of the parametrial areas, and then you can specifically see which of the 4 veins is refluxing, which is far more accurate and physiological than that, which I can do, because all I'm doing is size. They're doing actual reflux. Now, it has been my experience, frankly, that size does correlate with reflux in terms of pelvic veins, at least. So it isn't quite as big a deal as they say, but nonetheless, it's a huge advantage. And this is what it looks like. And when she gets the patient to bear down, you can see the veins flood with color. And for many of you, this may be very straightforward. And if that's the case, then good for you, because you're in a very fortunate position. I'm not, and I have to rely on other stuff. This was an article from Fergus Coakley a long time ago now, really, and talking about diameters of veins. I don't really use diameters. If they're impressive to me, how big is impressive? I suppose if impressive is approaching the size of the external iliac artery and vein. That's the kind of size we're talking about. So they're big puppies. Now these are classic images. You can see the left gonadal vein descending here into a leash of collaterals, which then go around the uterus. And this one is is the right ovarian vein, and this is going up the internal iliac vein into the IVC. And that's on MRV, and you can see slightly later phase, you can see intense parametrial varices. And this would give you a good roadmap, but again, you need good quality MRV. CTV is what we're good at here, because it's down and dirty, it's cheap, it's fast. There is a radiation dose. And so what are we looking for? Well, you're looking for big fat veins. These, believe it or not, are the right gonadal veins, the right ovarian veins. And as you can see, it's the same size as the right external iliac, or right common iliac artery. And likewise here, there's an enormous left gonadal vein, which has fallen slightly off to the side of the psoas, but you can see it's the same size as the external iliac. I'll try that again, as the common iliac artery. That's kind of what I use as my size criteria in terms of, are they big or not? Then down here, you see lots of varices around the uterus. And then in this particular patient, a leash of varices going into a right labial region. And obviously women aren't thrilled to talk about this area. It's usually post-childbirth. And for years, the symptoms go undiagnosed. And a lot of my patients have seen, they've been bounced from pillar to post. They've seen gynecologists, urologists, vascular surgeons. And a good few of them have been to see psychiatrists, or pain specialists, pudendal nerve blocks and so on. And the pathology is really right there in front of you, as it were. And that's quite irritating to me. you can see this coronary form, a huge varix here, and it's again larger than the common iliac artery. So I've modified Tony's technique. Tony simply put in a 5 French vascular sheath and then got a single 5 French multi-purpose angled cordis catheter and got into all the veins really, really quickly. And he was really fast. And I suppose if you've done 2,000 of them, that's great. I haven't done 2,000 or anywhere near it. I've probably done about, I don't know, maybe 150 now. What I found is that I find finding the gonadal veins quite easy. And obviously the left common iliac vein is easy. That's my office. And the intravascular ultrasound of the left common iliac vein is easy. So there's 3 veins that are relatively easy, but I find the pudendal veins difficult. So what I've done is change my technique slightly so that I can cannulate, ideally, the left gonadal vein, go down the gonadal vein across the parametrial varices and up the right side. And then with the second sheath, I can then cannulate the pudendal varices while I'm injecting in the ovarian veins. And that sounds cumbersome. I'm putting in an extra 10 French sheath here. It takes only a minute. I do it for all of my IVC and iliofemoral venous reconstructions. And so, you know, it's no big deal to put them in. And so the loop technique is very straightforward. And like most things in my life, it happened by accident the first time. And the wire just simply flew across from the left ovary over to the right. I was there, wow, I got to follow that. Where's that gone? And then it went up the far side. And then I got back in the IVC and I was like, oh, this is totally cool. So I've now gone from down the right internal jugular vein into the left gonadal, or left renal vein, left gonadal vein, across the uterus, and then back up like that. And then I realized, because Tony had a particular niche technique, and after dealing with the right ovarian vein from the top, he would get the back end of a stiff glide and deliberately dissect the orifice of the vein to make sure that there was no reflux into that vein. And again, his skill level is fairly exceptional. Now, sometimes you can't do the loop-to-loop. In other words, sometimes you can go down the left and you get into the parametrial varices and you see this big flush chunk of veins. And then you try and get your wire across and you can't. I don't give up at that stage. And that's why I've introduced the second sheath. And the reason for that is you usually can reflux into the right ovarian vein from that side. And when that occurs, then you can use that as a roadmap to find the orifice of the right ovarian vein, because I find that quite difficult. Once you're in there, then you can deal with all of the ovarian pathology right there. But you also get a lot of reflux into the pudendal veins in the pelvis. And so while I've got a catheter in the ovarian veins, if I can use a second catheter to find the pudendal veins, which are pre-filling with contrast, it saves me time. I'm not saying you have to do it. I'm just saying it's the way I do it. And then at the end of it all, I use intravascular ultrasound to assess the left common iliac vein stent. Now, I did have some very cool videos to show you, but unfortunately, because I'm such a technological donkey, I wasn't able to delete the name. And so we had to take the videos out, and I apologize. So this is coming from above, and you can see we've gone into the left ovarian vein. Here's the left renal pelvis and proximal left ureter. Down along here, you can see we've gone across the parametrial varices, and now we're up the far side here. Once you get up to the top here, you can see the junction with the ovarian vein and the IVC is right there. You then basically coil and foam. If I was doing it nowadays, I would have put my coils much higher. This is quite a few years ago. I would have put my coils much higher here. And then you'll often get a collateral here, and I'd use more foam between here and here, or probably I'd use something like an hourglass, which is quite a nice embolization device, which you'll be seeing in the next year or two. It's from the States. You then come down here, and you then get into this area here, and you do a parametrial injection. At that level, then I use foam to ablate all of the parametrial varices on that side. And then I pull my catheter back, do another parametrial injection, use your contrast to perform a venogram. And with a second catheter, then you see you can get into the internal iliac easily and find these other ones if you can't get into them. Because you might have to put coils much further down. If you're just using foam up here, the chances are you're not going to get a perfect result. And then you lay coils all the way up along like that. And that's the loop-the-loop. The pudendal injection pattern is something that Tony Lopez is much, much better at than I am. And he gets this typical It's like spectacles, the obturator veins, or the obturator orifices. And he can quite easily, as I can as well, get a catheter from left to right or right to left across the pudenda right here. And I've learned from experience not to put coils in the center portion for obvious reasons. But this is what it looks like. You get a leash of collaterals, and often it spills right down into the parametrial region. And I can tell you from experience, it's easier to foam from above than puncture the labia from below. Even if you're doing it under general anesthetic, puncturing the labia is really difficult because it's very soft and it moves a lot. So it's just a difficult vein to hit. And if you're doing it awake, the patient is not really going to send you a Christmas card, funnily enough. Intravascular ultrasound, you're all very familiar with this. This is like teach you to suck eggs. You can see that we've got basically an obliterated left common iliac vein here with the right common iliac artery on top of it. And this is again from quite some time ago. And this is, looks like a Vici, I'd say. I've landed it too far. I mean, the spinous process is there and the pedicle is here. Ideally, this would have been down about this level here. Haven't quite covered the far side, but it's a little bit too far into the IVC. And finally, this is an interesting paper that just came across my radar. This is a friend of mine, or a fellow who used to work with whom I used to work in Chicago, called Stephen Smith. And he's an interesting guy. And the gist of it is that he's started seeing a lot of patients who've been diagnosed with migraine. And in fact, when they look into things, they've got a postural orthostatic tachycardia syndrome. Now, to be honest, I know nothing about POTS, and I always thought it kind of fell into the slightly quacky area. But he sends these patients to the Mayo Clinic, and they are investigated. They've got a full-on physiology lab, so they put the patients supine for a while, and they tilt them one way or another and measure all sorts of stuff. I don't know, is this real or not? But I have to say, it's a very, very interesting paper. I have seen lots of patients over the years with difficult to pin down symptoms that have improved massively after pelvic vein embolization. Obvious enough things like obviously hemorrhoids, that's a straightforward one, but irritable bowel syndrome, people diagnosed with irritable bowel for years that have got better. People diagnosed with interstitial cystitis for years that have got better. And again, you might say, oh, they're all kind of linked like that. But I've also had quite a few patients with migraine who've improved, you know, and you're like, migraine? What the hell has that got to do with anything? So there's something in this, and it's going to be the next generation who are going to find out about it, not old codgers like me. But I think there's something there, and I hope the loop technique is handy for you. Thank you very much.
That's fantastic, Jerry. I'll tell you, how hard is it to get that catheter across the parametrial veins up the right?
Up to right. You know, it's funny. As I said, the first time it happened to me, I was just. In fact, this is my most embarrassing moment. Like, it's like not looking at the golf hole and getting a hole in one, or not quite, but like pretending to look over that way and then holding about a 90-foot putt across slopes and curves. I was actually, this is really embarrassing. I definitely shouldn't tell you this because everything I do is obviously very careful. But I was actually exchanging a catheter out, and I was simply pushing the wire and looking away this way. And then I re-screened, and the next thing, the wire was all the way across. I was like, oh, we've discovered something. Oh. And so then I followed with the catheter, and I was there, actually, this could be kind of cool. So when I got across, I was sadly very excited, you know, and I know that you guys are thinking, mates, you know. But I thought, oh, this is really cool, because then I was on the far side, and then I thought, oh, okay. So now I can treat all of the right from the left. So I actually do go and try and do it now, because when it happens, it really shortens the procedure, because you go down the IVC, you go into the left first and then across, and then you can nail the two veins really quickly. But the biggest advantage of all, funnily enough, is once you're across there and you've got both ovarian veins dealt with by one catheter, then you've got your second catheter to go and search for those pudendal varices, which I find much harder. Now, other people might find the pudendal varices really easy. I don't. So if I've got a roadmap to get into them, I find that a lot easier.
Well, I mean, that leads up to another question. Like, Jonathan, you go with yours first, and then I'll.
Oh, sorry. I was just going to say that was an excellent presentation, and I did also enjoy the loop. What I've found is there seems to be two populations of patients. One set of patients with very left-sided symptoms and even unilateral varicose veins and things. And then the patients, as you described, with the bilateral symptoms and image findings. In those patients with the more unilateral symptoms and congested pelvic vessels, do you always chase the right side, or do you sometimes leave patients with just one side treated?
No, I always go for both. There's a nice paper from a guy from Zaragoza in Spain called Miguel Angel de Gregorio, and he's an interventionalist, but he does 4 veins all the time. I have a slide that I didn't put up, whereby the Lopez or Whiteley group looked at their analysis of 1,000 patients. I have to laugh. Their numbers are brilliant. Like, it's like, here am I doing well in my 17 patients. I found this out, and they're like, yeah, well, in our 1,000, and you're like, oh. Anyway, but they found, so left ovarian and bilateral internal iliac was by far the most common population. Left ovarian, and then the 4 vessels were less common. Isolated right ovarian was almost never. So if you, as I said, and that's the big advantage, Jonathan, of having a Doppler expert, if you've got somebody who can give you that information, it would definitely save you time. I'm basically trying to treat every damn vein I can get into, and that adds a lot of time to the procedure. So I have to allow 2 hours for these procedures, which, like, I do a fibroid embolization in about 22 minutes, you know what I mean? So varicoceles, 1 vein, I allow 20 minutes, So they're time consuming, and I think it would be a big advantage not to have to treat them, all of them, I mean, but equally going back the second time is an even bigger pain in the arse, because then you've already dealt with the easy ones. Now you're in the harder ones, and I find that, and the patients then they've kind of lost a bit of faith in you, you've lost a bit of ground, because usually if you get it right, it's fantastic. Like the patients, it is night and day. I had a woman in January who was, she came in, she looked shattered. And I said, are you sleeping well? She said, no. She said, I go to bed, I water deprive from 6 o'clock. She knew the terms, she wasn't, a lot of the women, as you know, are very sharp, but she was very psychologically, very normal. She said, I water deprive from around 6 o'clock. I empty my bladder. I go to bed at around 10. I sleep like a baby until about 10 or about 12:30. Then I wake up wide awake, and then I have to go to the bathroom 6 times at night. And she's passing like 10 mils each time. She said, and it was a very good description. I thought, I get into bed and I lie down, and I can feel worms running over my bladder like this, and it's definitely the veins. So anyway, I did the full 4 vessels, treated them, and she came in. She looked about 10 years younger. You swear I was a plastic surgeon. I was so proud. She looked amazing, and I said, like, what's going on? She said, I'm sleeping. That's it. She said, I'm sleeping, right? And I said the rest of it, and like most women, you ask them, well, is the dyspareunia better? And she's like, who gives a about the dyspareunia? I can sleep at night. And I'm like, yeah, okay, but is it better? She said, way better. I'm like, okay, well, that might help a bit as well. She said, nah, it's because I sleep. And I'm like, okay, I got the picture. So yeah, but they're a challenging group of patients. They're in their own way, they're as hard as dealing with diabetic baloney disease, you know what I mean? Because you really want well for these patients. They didn't deserve any of this crap, and yet they've ended up very symptomatic. And because there's no good test for it, I find them challenging. So I spend a lot of time on the history. And if I'm not happy about the history, I probably don't go there. They got to have fairly characteristic symptoms, If you got obvious things like pudendal varices, that's fine. But that's a very small proportion. It's usually the pelvic symptomatology, and you're thinking about endometriosis, and I know nothing about endometriosis, but it's a tricky area. That's all I'd say. I think for me, a good relationship with a gynecologist is a big advantage. I get sent quite a few of them now they've had a laparoscopy. They take a picture, and there are these veins the size of Texas like they're nearly filling the screen. You're like, okay, I could treat that. Even I can get into that,
Yeah. I think,
Jerry,
10 years ago. Sorry, Steve, go for it.
Yeah. I was just gonna comment. I'm in a very close proximity to the Whiteley Clinic where we work, and I think the one caveat I'd just say to everybody about the pelvic transvaginal ultrasound is the difference between physiological and pathological reflux. If you do transvaginal ultrasound on everybody, you're going to pick up 4-vessel reflux in any woman of probably over the age of 30 who's had children. And if you're using that, which they do there, to guide your coil embolization, you will coil everything. So even though the data suggests, 3 in most, your treatment strategy on the downside of all of this, if you get this wrong, the significant pelvic pain that comes from too many coils is just as bad as too few coils.
Really?
And that is very difficult to fix once you've embolized the hell out of everything. So like all these things, I think Jerry's point about a really good history and a detailed, that time spent with the patient in the beginning, getting to grips with the history is really important. It's not just about stopping varicose veins coming back again, which is...
Yeah, and I was being somewhat polite. Stephen Black was being very circumspect about that specific aspect. There have been criticisms over the years that there's been overembolization. Frankly, there's been overembolization from that specific group of people. And they take a very aggressive approach to treating varicose veins, primary varicose veins. Now, that is one thing I really do have a problem with, so that they're treating patients who are females with a couple of kids. All patients are getting a transvaginal ultrasound at the beginning with primary varicose veins. And you're like, hang on a second now. Like, I mean, the vast majority of these people can be treated as a day case with foam or radiofrequency ablation or whatever. And yet they're ending up with I would regard it as quite a maximally invasive pelvic vein embolization, because in their opinion, it increases their recurrence-free rate from say 91% up to 98%, so you're doing a very invasive procedure, a 2-hour procedure in my hands, and maybe a lot less in others, to get a 7% gain. And I agree with Stephen's point. That's hard. I don't know. I find that I'm uncomfortable with that,
I'll just stop there, Jerry, for a second. There's 2 things that I want to go through. Firstly, a question from Sarah Thomas. She has a question about a patient of hers, and I assume that this is IVC atresia. She's a patient with IVC atresia. She has a dilated ovarian vein and major pelvic congestion syndrome. And she wants to know, what's your experience with this, and how would you approach the ovarian vein?
Well, thanks, Sarah. Nice, easy one early in the morning, huh? or late in the evening in Oz. I have seen catastrophic results from patients with similar stories, say post-iliofemoral DVT, when clearly the ovarian vein was a route of bypass up from the left internal iliac vein up to the left renal vein. And I saw a patient referred about 5 years ago who had embolization of the left ovarian vein, and things got way worse. It's because it was clearly a bypass, you know what I mean? Because the left common iliac vein was completely blocked. With atresia of the IVC, if their only symptom is pelvic varices, I'll open that one up to Rick or Stephen. I don't know. I personally would be almost more, if they've got, it is rare in my experience for patients with IVC atresia to have no lower limb symptoms. And Stephen Black's group have just published an amazing paper, and actually had a patient just last week, Stephen, with it. So for IVC atresia, the patient's only complaint was shortness of breath. Unfortunately, they wouldn't do an echo on the morning of the procedure. The gist of it was he was very short of breath. He's a farmer, and he's got IVC blocked down to his femoral veins bilaterally. And so we reconstructed him, and 2 weeks later, once his back pain had eased off, his shortness of breath had completely disappeared, like totally. It was amazing. This is a strong farmer going up hills who up until then, he was trying to buy some 4x4 to go up this pathetic little hill, Coming back to the question, I apologize for ranting for a second. Patients with IVC atresia, in my experience, are rarely truly asymptomatic. And I would be more inclined to consider treatment of the entire IVC problem and then dealing with the ovarian veins afterwards. If he only has pelvic vein congestion syndrome, I might be then tempted to foam just the parametrial varices and leave the ovarian vein. I don't know. I'd find that a hard one. What do you guys think? What do you think, Rick?
Well, it got me actually thinking about that vena cava stenting that we do, and I always say that that renal the renals are not a problem, right? So say, okay, so the kidney is not going to harm from that, or so. But what might happen is that, of course, the ovarian vein then is a collateral, and then the patient has a open IVC, but now pelvic congestion syndrome. So going to the so we never tested that actually, if that might happen. So that might be something. And for treatment, I think that principally you should not, just top of my head, embolize then the ovarian vein, because that is the collateral from the renal vein. So what happened then is that the renal veins is creating all kinds of collaterals, and then you get the typical flank pain and more collaterals, and you don't even get to that. So and I have no experience, but I'm just theoretically thinking about now what you can do if it's a very severe problem. Why not recanalize the renal vein into the closed IVC, stent the IVC, and make some kind of chimney configuration with the.
I'll bet you. I love Sarah. That's a fair point. I'd love Sarah to come back in. I would strongly suspect the suprarenal IVC is open. In fact, I've never seen somebody who hasn't got a. I would expect that it's blocked below the renal veins, because in which case you've just got to get from below the renal veins to, say, the external iliac veins bilaterally. But I accept your point. I don't know if there's a right or wrong answer on that, but if Sarah could come back in there and tell us, I suspect the suprarenal IVC is open. So let's just assume, for the sake of argument, Rick, that the suprarenal IVC is open.
Well, Sarah's come back and she said, yes, indeed, suprarenal is okay.
Okay. So I still don't have an answer. I don't know if anybody does. What do you think, Stephen Black?
I mean, I tend to think that these patients with significant obstruction, I tend to favor treating the obstruction first, because often this is a pressure phenomenon. And if you've got pelvic veins that are trying to drain into an occluded IVC, regardless of the gonadal drainage that you may have, the rest of the pelvis is not draining properly. So looking at the obstruction, particularly if the suprarenal veins are okay and you've got decent inflow vessels, then that reconstruction then tends to work. So I treat that first, but then you do frequently then have to go back and deal with pelvic vein reflux. And Yakush Desai presented a great case of that expert venous management. He had done an iliac vein stenting procedure on somebody who then still had persistent groin pain. And he then went and embolized the internal draining into that previously occluded left common iliac vein, and then her pain was gone. So all of these patients, I don't think there's a simple answer to any of them. You look at the pattern, and it's a combination of obstruction and reflux. You've got to try and work out which one is worst and deal with that first. So if in this case,
grab that point off you, Jerry, you mentioned it about a refluxing internal iliac vein, and Steve, you have too. In the presence of no obstruction, such as a May-Thurner or something, you've got pelvic congestion syndrome and maybe some pelvic escape veins. What do you think about an refluxing internal iliac vein? Is it important? Should we be looking at that further?
I think it's part of the. You mean in terms of pelvic varices and pelvic congestion symptoms? Yeah. Oh well, exactly. I think that a lot of the patients do have refluxing internal iliacs, and they don't necessarily have a May-Turner, because I know that they have it on the right side as well as the left. So when I say refluxing internals now, I'm saying when I inject into, say, the proximal internal, not with a balloon occlusion catheter, just with a regular catheter, and you get filling all the way south into the pudendal veins, then I'm inclined to believe that's likely to be real, and I would treat that for sure. So I think that, to me, it's just a constellation of stuff. You're looking for the biggest veins you can. I take Stephen Black's caveat about transvaginal ultrasound, because you are right. I mean, on a different level, if I look at CTVs or MRVs in women who've had more than 2 kids, they all have big gonadal veins, every single one of them. And so you could end up treating, a huge number of people, which is just about the last thing I want to do. So refluxing internal iliac veins for me are part of the picture, and I would be treating them myself. Yeah.
Steve, do you think the same way, and Rick?
Yeah, I take, I find this is complicated, isn't it? There's no simple answer here. And if you just treat what you see in front of you and you see reflux, treat reflux, you're going to end up finding you're over-treating patients massively. So, each patient, you got to work out the symptoms, you work out what bits of obstruction and reflux you can see, and then I tend to go after these things in a stepwise fashion. So Jerry made the point earlier on about the patients lose faith in you, but only if they're expecting a miracle at the first one. What I tell them is we're going to do the gonadal vein, left gonadal vein first, if that's the dominant reflux pattern, see how you get on. If that doesn't work, we'll come back and do the internal iliac veins.
That's good.
And that's, it may be a more conservative approach, but I do think that I found a lot of patients are better after that left gonadal vein reflux. And I listened to a very good talk from the professor of IR, I've forgotten her name now, from Los Angeles, who's done a lot of pelvic vein embolization. And over time, they've gone from doing all 4 veins at the start to a stepwise approach to this. So the main advocate for treating everything is Mark Whiteley, of course. And I think that I am skeptical.
Okay, that's good to know.
I'm not being my usual direct self here, because I'm not sure.
No, that's okay. I mean, that's actually really useful.
I'm actually going to cut us off there because we've got to keep moving along, guys. Yeah. We could talk about this all day because I've got a few other questions, but I won't. I'm going to move on to take the screen off you. So our next speaker is going to be Rick de Graaf. Now, Rick's an interventional radiologist in Germany, and he's going to talk to us about renal vein IVUS and stenting. And I think this joins in quite nicely because maybe we can link this in with such as somebody with nutcracker syndrome and an ovarian vein incompetence, and whether we should be treating that too. But I'll let you get on with that, Rick. I'll hand it over to you.
Okay. So you see the screen?
Got it.
And actually, yeah, it's supposed to follow Jerry, and that was perfect and very helpful. And I think that that is very illustrative of that one physician is doing so many cases, because as we know in deep venous disease that we actually only doing in Europe on a broader scale since 2000 and let's say 2009, 2008 maybe. The same might count for pelvic congestion syndrome, that only a couple of centers are doing them and having expertise and doing a lot. But on general basis, I think it's completely underdiagnosed and misdiagnosed and undertreated for sure. And I think that pelvic congestion syndrome should first really look for the reason why. So basically, the patient come to a gynecologist, and from there on, hopefully the gynecologist is going to find an endovascular specialist that they think, okay, there might be something there, and let's do a diagnosis and then maybe treatment. But even if that happens, then you need to find an endovascular specialist that's aware of all the possibilities of all the treatment options. So not only embolization and coiling, but also stenting of the different compression syndromes, and being aware that there is something as a compression syndrome that might lead to pelvic congestion syndrome. So yes, we have the ovarian vein incompetence, and can embolize that, and Jerry showed that very, very nicely, what all the tricks and possibilities are. And they also mentioned the maternal compression, by which pelvic congestion syndrome might occur. That's relatively easy and uncomplicated to treat with stenting. We heard about that for more than 2 decades now, and many centers are doing that on a regular basis. Nutcracker phenomenon, I would say, not nutcracker syndrome, because in the literature, nutcracker syndrome has a different ring to it. But a nutcracker phenomenon where the renal vein, left renal vein, is stenosed or obstructed, compressed from the outside, that might be a reason to treat the pelvic congestion syndrome. That can be done by stenting, open surgery, minimal invasive surgery, and there are multiple reports on that, specifically from France, from Hatung. who have some very wide experience with that. Before, as I mentioned, nutcracker phenomenon, nutcracker syndrome. The problem with nutcracker syndrome, and I still hear that. So they say, yeah, well, it's not really a significant problem, that stenosis, because we do not have any blood in the urine. We do not have flank pain. We do not have this. The specifics, we do not have a 3 millimeters of mercury pressure gradient. Well, of course, you're not going to get that when you have a large gonadal vein going down, causing a pelvic congestion syndrome. So you do not have those typical nutcracker syndrome symptoms, but you do have a pelvic congestion syndrome because everything is running into the collateral, i.e. gonadal vein. So let me show you a typical case. I would say that you might encounter in less experienced centers. So there's a female, 48 years old, and pelvic complaints, pelvic congestion syndrome. And 2011, that was here in Friedrichshafen before I came. 2011, there was an angiography, and well, there was some signs of a common iliac vein. So there was a PTA, angioplasty, performed, and that already illustrates the lack of experience, only doing a PTA, not stenting. Then later there was a CTV because there was still complaints, and they found a large ovarian vein, so it was embolized. Well, that for a short period of time made it a little bit better, but not completely. So back into the angio, and they saw again those signs of the common iliac vein compression, and it was stented. Yeah, but that went on for a little while, and maybe the complaints were better, maybe not so much, because in January 2012, a re-angio and a re-embolization. That's typical, as I just mentioned. You embolize a collateral ovarian vein, and then later on you have to embolize again and embolize again, because there's a pressure gradient, and the body will find new ways to circumvent that obstruction. So finally, 2019, patient came to me here back. So I did a MR venography. It was very obvious for me what was going on. And this is still the CT venography from back then. You see a very tight stenosis of the left renal vein and a large ovarian vein. So back then it was already obvious that there was a very tight stenosis. Okay, you can debate that. Is it stretching? Is it because the patient is lying on the back and not when she's standing, etc., etc. There's all kind of debates. That's all. That's a May-Turner, of course, that was showing there. So, but that debate I would love to have in a couple of minutes. So there was before embolization 2011. Let me go back. Oh yeah, from here. See the washout of contrast. That's something that I want to talk about over and over again. That washout of contrast. It is not really possible in my view. Such a strong washout when the patient is lying on the back, because there's no pressure gradient based upon hydrostatic pressure. So this is the renal vein angio from 2019. See all those collaterals that formed because of the ovarian vein is embolized. The blood needs to go somewhere and cannot go through the renal vein. So naturally, the problem is there. So we stented. So what we did is do an IVUS. That's something I'm tell you about in a couple of minutes. How I think that you should approach that entire all those cases with MR venography and a very, very extensive venography with IVUS. So this is the IVUS of the stent, because there was still possibility that the stent might be occluded, right? So because you cannot see that on the MR venography very, very accurately. So I did an IVUS on that. So the stent was patent, yes, a little bit compressed. That's what those stents did back then. That there was a wall stent, and was still fairly open, and I didn't see any signs on the angiography that there was an obstruction. So I left that alone. I was happy with the IVUS on that, but I was not so happy with the IVUS here of the renal vein, because going in here, this is the overlying AMS, aorta, and right. So this is the vena cava of the left renal vein, severely obstructed. This is something that, in any case, a common iliac vein if it would be in a common iliac vein or something somewhere else, you would stent that. So yes, I stented that, and the complaints disappeared. So I'm not going to show you that case. Didn't get to that, but I'm going to show you some kind of live case that I did back then in Maastricht. Similar idea. So this was the angio from the left renal vein, and you see again that very strong washout of contrast, right, with the patient lying on the table horizontally. So that is a sign of renal obstruction and backflow. So going to that in that gonadal vein, not to embolize it, but to get that very large stent French sheath in there, because that might be a tricky thing to do. So I changed that for a stiff guide wire, like an M-plaster or something, and I push that back deeply into that, and then finally you can push in the 10 French sheath and do a balloon PTA, I think, and that's the next. Yeah, right. So there's a sheath. So let's go on to the next one to do a PTA. Oh, you all know what an indentation in the balloon means, right? There is a significant lesion. So that's very convincing, I would say, and balloon that all the way down. In the sake of time, I'll just pause that, and then get the sheath inside. That's always very important if you want to stent, because of the anatomy and the way the veins can move there. It's very difficult to push in a stent, or it might be difficult. So with the sheath in, I'll find my landing spot here. So it's a varicose vein. So do not go, of course, into one of the renal branches, but as far inside as possible. So I find a nice landing spot there, and go with a sinus venous stent. Here, this is the sheath. So the stent is still going there with the wire still in the ovarian vein, but now pulling it out and then slowly moving ahead into the renal vein branch, and then push the stent inside and the sheath a little bit back. This stent is still, I would say, my favorite. I went all different ways, but I will tell you about the other stents in a minute. It's difficult to position for sure, but you can crimp it a little bit, so you can make it a little bit shorter, and that's important so you don't have a large part of the stent sticking out in the IVUS, and you can position this very, very accurately, and it's not really, it's not too smooth, so it cannot migrate very easily. Okay, so a little bit too fast. So this is the way to deploy. Very slowly, pushing a little bit out, and pulling on the delivery system. But you see that how slowly I do that. It's no. This is really, I think it's a very dangerous. Yeah, will come with some dangerous thing to do, and I'll show you why in a minute. So slowly going back, and I would like to land the last segment of that stent on this area. So you still see the indentation there, and okay, so deployed, and then the angio afterwards. You see there's still some backflow, but not that strong washout anymore. So yes, then the idea is to put here some coils to prevent that little backflow that still is there, probably because of a small stenosis. But you do not, at least I do not, embolize the ovarian vein and then leave that stenosis, that obstruction behind. So this is what I really want to warn you about, and it's also in the literature. Those stent migrations are not to be sneezed at or laughed at. Those really occur, and those can be disastrous. In this case also, maybe I undersized it. I still don't believe that I actually did. I think that it was a stent issue, but maybe you overtreat it, right? So it's not really a tight stenosis, and the stent might migrate, or you use the wrong stent. Anything is possible, but it really does happen. And when the stent ends up in the heart. That's not a thing that's I would say in relation to the complaints of the patient. So we can talk about that, all the stent configurations and the ways how to stand it, and maybe oversize in what manner, etc., etc. That would be nice for a discussion. But I really want to show you this possibility, this danger that of a stent migration. It's not a very easy thing to do. So in summary, so when there's suspicion of pelvic congestion syndrome, I think that's MR venography we do. I mean, I cannot say that everybody should do it, because MR venography is not always in every center the best modality, but a full angiography examination is definitely advised. And what do I mean with that? So I go from unilateral side most of the time the left side, and do the iliacs and cross over and the internal iliacs and do everything there. Then the right and the left renal vein and the ovarian vein. All of that, of course, with a patient supine. And then there I have an issue, because I have a very modern angio station, and I have a tilting table, all fine and good, but it's not good enough, I think, to show exactly the hemodynamics that are going on in pelvic congestion syndrome. So I think you should really have a table that can be completely vertical, so let the patient stand. Definitely exclude the obstruction of the left common iliac vein and renal vein. I totally agree with Stephen to say that they should do it stepwise. The least dangerous procedure first, the most likely culprit to attack first, and then have the patient back on a close watch and see what's going on. Do maybe another angiography. Definitely not treat everything at the same time. And when there's a renal vein obstruction, definitely do not embolize the ovarian vein, because that might make things worse for the patient. So therefore you need, I think, absolutely IVUS, and it's very valuable, and I think even more so than in the disease that we used it already so rigorously in deep venous obstruction. So definitely use IVUS as well in pelvic congestion syndrome. Thank you very much.
Thank you very much, Rick. That was excellent. Once again, I'm sure my practice will benefit from your wisdom on this side of the planet, as I've seen several of your lectures now. I think the point you made about watching the flow of contrast in that initial venogram when you are treating gonadal veins is very important in defining who has these nutcracker type syndromes. I'm getting to a question, but I just wanted to, basically the question I wanted to know was, I had a case, standard gonadal vein embolization, treated, and I always do a pre and post renal venogram, and you know, before I started coiling the gonadal vein, there was no reflux into the gonadal vein, and afterwards everything from the kidney was going into the IVC. So I was happy there was no restriction for that lady or evidence of nutcracker syndrome. However, she came back to me at the 6-month follow-up, and she said, my symptoms for 5 or 6 months, for most of the time, were perfect, but recently they've come back. And I noticed at clinic, she got a lot skinnier. And I know it's controversial, patient's weight and this nutcracker syndrome. But anyway, I got her back on the table, and she had developed a new gonadal system that was equal, if not larger, than the one I'd previously treated. And she had, you could watch the contrast go all the way around to the other side. And I ended up putting in a stent, as you'd previously instructed in your lectures. I just wondered if you'd ever experienced that, where patients have come back with that change in weight or anything else?
Not specifically that change in weight. What I I have a patient, let's say, waiting because she's completely confused right now. She doesn't have it, then she does have it, then you see it on angiography, then you don't see it on angiography. I mean, I didn't do all the examinations. She's going all over the world with the same problem to all different specialists. And I see the pictures and the comments or the reports from the physicians, and they did ultrasound and everything, and sometimes they see it, and then a couple of months later somebody doesn't see it. So there might be something actually there that we absolutely do not understand, and I think that's why I'm a little bit also. So in Maastricht I did it quite well, a lot. Definitely not dozens and dozens of it, but here I'm a little bit more conservative because I thought I understood it, and I do not really understand it, I think, anymore very well, and that's why I now put all the patients in standing position and then do the IVUS again. That's a very difficult thing to do, by the way, but
sorry, did you just say you're doing IVUS and you get the patients to stand up on the table?
Standing. So what you do is putting a sterile table next to it, and then lead the IVUS through the sheath. So I put in the sheath, then put the patient vertically, then have the sterile table on the left side of you, right. and then afterwards, just like no, I have no comparison. So and then just pushing it down. So
Germans are much more tolerant than us.
I'll tell you what.
Hey, Germans.
Health and safety would be jumping all over me. Like I can imagine the patient would fall over, the IVUS would get pulled out. You know, I mean, I can just see it all, a catastrophe of epic proportions. But Rick,
it's the contrast of swearing and soft toys, Jerry, that's the most disturbing.
So just come back to this for a second, Rick. You stand the patients up because, no, and I'm not trying to give you a hard time. You stand the patients up because you feel that that is a more physiological position, and that, no, sorry.
No, I'm doing that because I've gotten in multiple discussions and more now that physicians, colleagues are challenging me. That say, yeah, well, you did a CT or the MR, not for you, whatever. In line position, everything changes.
Oh, I see. Okay.
But, hey, Rick, have you ever thought about doing ultrasound? Like we do this for our nutcracker syndromes, the young girls. We actually get them lying on their back. We compare them with them standing like on all fours and on their side, and we look at the nutcracker and how it relates to that. Have you ever done that?
No, maybe I'm just not good enough at that. So I really believe in that entire. So I also do the angiography, right, standing up. So I'm there, and I'm also doing the IVUS. So
wow.
It's a complete angiography. So in this, just go back to the thing. So I'm not that arrogant that everything that I said before.
Not that arrogant.
Is not that arrogant. So I think that's right. So that's why I went back and I said, okay, so I need to find that out. What's really going on? So far, I did not have a definite. I didn't find a definite answer, to be honest. But
well, fair dues to you for looking, man. It hadn't even crossed my mind. Speaking to the people who've done a lot of renal vein stenting, and I'd be thinking particularly about Mark Meissner in the States, in Seattle, and Peter Glavici. They have had to take out a lot of renal vein stents as well. And they say that one of the biggest aspects is the impingement upon the superior mesenteric artery, actually, Jonathan, to come back to that point, that the stent, because I suspect they're using older type of wall stents, that the stent is actually, the major reason is pain from the stent. And when they actually take out the stent, there's an actual divot into the front of the aorta, and equally the back of the SMA is pinched, and they have talked quite a lot about weight loss and the angle. I've never measured it myself, but I mean, like, I think that renal vein stenosis is a very difficult one. I like Rick's idea of doing the IVUS. I wonder, Rick, now that you do so much more from the neck, would you be prepared to do all of the IVUS work from the neck as well? It would give you a nicer angle into the left renal vein, but I don't know.
I appreciate that you think that I'm very tall, but I'm not that tall that I can work with an IVUS from there in the
oh shit, no, yeah, not if you're going to get the patient standing up. Anna, for God's sake, I mean, the standing up thing, come on, let's banana around this.
I'll be standing on the stool and everything. Right? That might be.
I did wonder, was your scrub assistant altitudinally challenged? And then I remember that you're actually a giraffe. So she's probably like 5'10", you know, and you're just like 6'12", you know. So anyway,
the jugular vein is definitely a nice tissue, but I don't like to stand at least from jugular vein, because I think that's also maybe,
hey,
I think that maybe
I've never done a renal vein stent, so I'm not gonna throw any and by the way, folks, if Rick could ever show you next time we do this, he's got to show you the renal vein stent that moved and then he got it back. It's the coolest case ever. We had a thing at VEITH a few years ago where we had a big donkey hat. You remember that? And then we had a barometer for the donkey. What do we call it? It was like your donkey points or DPs. And my one was particularly stupid. I stented the wrong vein entirely. But then when Rick started to show his case, his donkey points were like woof. But then he rescued it, and unfortunately, I beat him again for being a donkey.
Oh,
great.
Can I get a consensus of you guys? Who would stent a renal vein in this current day and age with the facilities and the tools that we have available?
I would not.
Month.
I've never done one.
Okay, Steve is a no. What, Jerry?
I've never done one. Never.
Nope. So no. Rick, you still do it?
Yeah, I still do it, but I'm more conservative. So I'm really want to make absolutely sure that it's because of that stenosis. Because I agree that maybe there's something going on that we do not know, and it's fluctuable, fluctuating, or sometimes it's highly on IVUS. It's highly significant, and the next time maybe it's not, and maybe my wire can pull the vein, and thereby it looks stenotic on IVUS. I agree with all those ideas, and I'm thinking about it, but still there are some cases with an absolutely fast retrograde flow into the ovarian vein with that washout. I think that must be it. Or the patient that come to me that already have had multiple coilings and do not get better, and you see that large collaterals developing around the kidney. That's also not a good sign. Okay. I think, and I understand. In the presence of a refluxing ovarian vein and a May-Thurner syndrome, your first port of call would go to stenting the May-Thurner. Yep. Cool. Yes. I just want to make that point for everybody out there. We've got a question from Jane Lee. Rick, this is for you. Do you measure pressure gradient across the renal vein? No use, in my opinion, because if there's pressure gradient, then the body will definitely find a way to make a collateral. So with the collateral, the pressure gradient is not accurate anymore. So it has absolutely no use. Pressure gradients in venous, in my opinion, has no use whatsoever. Okay.
No, tell us how you really feel, Rick. Just get it off your chest there. Did you say that renal pressure gradients in veins have no use whatsoever? And then you're you should put it in the right of the word, just to make sure that you're just quoting you now. Just quoting you.
Yeah.
Steve Black, you had something you wanted to say?
I think I was going to say the main point with all these patients, the same as pelvic congestion, is it's really difficult with the current tools we have to be clear what drives pathology. So, you have nutcracker patients. If you look at Glavitsky's publication, out of those patients, they all got treated in different ways. The response to symptoms is totally different. And this comes from the Mayo Clinic, where they probably know more than anybody else about treating this. The same with Mark Myers, and they know more about anybody else. So in the absence of tests that can tell you definitively that it's a nutcracker or it's a May-Thurner, or whatever it is, to me, the best approach with all these patients is start with the simplest and least complicated thing first, because some people get better if you treat the May-Thurner. Some people get better if you get rid of some varicose veins. There are patients who have clear nutcracker syndrome and have the kidney removed and do not get better. We don't understand this enough to be definitive on anything in it. You just got to be very considered and very careful, and take the patients on that journey to solve the problem for them. That's the way I'd approach it.
One final thing, Rick, you got me thinking about a few years ago. We had this patient was a long distance cyclist, and he came off his bike and had a massive pulmonary embolus and just survived. So I was thinking, you know, in cyclists, they get iliac artery endofibrosis. And I thought, well, I wonder the hell if that happens in veins, you know? So there's one place in Europe where they do a lot of cycling in the winter, and that's in Tenerife. So Manuel Menar, in fact, has had quite a few patients who've come off their bicycles after a long sprint, specifically after the long tuck, okay? So when they're bending over on the bike and they're getting as aerodynamic as possible, and getting as low, so they're getting their chin almost under the handlebar, right? They then sit up, boom, massive PE. And so what he started doing is he's been doing venography and IVUS of guys on bicycles with catheters in their neck and the thing through the catheter through the iliac veins as the guy cycles. But they haven't been doing it with intravascular ultrasound. So I'm going to have to put him onto, but they've been doing it from the neck. And it's a hilarious picture. There's this guy in cycling gear with his shirt off. Then he's got a catheter in his neck. And then they're doing the venography with him in different angles. It's the funniest. It's mad. Like, they haven't published yet, but I got to admire them. So you've gone way up in my estimation for your madness quotient, like doing crazy things that none of the rest of us are the hell doing. But good for you, man. At least you're still thinking, because I think the big point that Stephen Black made much more eloquently at the end is we don't know all the answers. And so we've still got to keep looking, you know, still got to keep looking.
And go to Tenerife, because you can also play golf there. And some weird patients.
All right, I'm going to move us right along. Where are we? I've got to get onto this. How do I get that? All right, our next speaker is Dr. Stephen Black, who is well known to everybody. Stephen is going to be talking to us about optimizing outcomes from DVT management. So, Steve, I'm going to hand it over to you if you don't mind. And
okay.
Take it away.
Thanks, Steve. So I'm very grateful to the previous two speakers for being so good about keeping to time, so that I didn't have to worry about rushing on my slides while we're 5 minutes over. I've got used to this with both Jerry and Rick, and I love them for it. So the first thing I'd say about optimizing your technique for anything really, and this probably applies to everything we've just done, is learn about it. So, you know, spend some time, like we're doing on this course, talking about things and with people who've done it before, because there's no medals for going out in a hubristic fashion to treat patients in a way that you think you know what you're doing, but you don't. So get to know the data, get to know the techniques. I found it better to take photographs with people who are shorter than me. I don't have any photographs with me and Rick because they would just be embarrassing and pointless. So I chose Olivia and Peter Neglin because you know, they look better optically. And the point about that was I spent an awful lot of time in the very beginning of treating these patients with Peter Neglin, with Olivia, with Jerry, with Rick, with Neil Speckard, with a lot of other people. And that learning continues now. Every single time we have a course or a workshop, you're picking something up from people that makes a difference to your talk. You know, and the other thing about it is when you're starting something off, you want to have people on the phone who you can talk to. I found early on in my practice, when I started sitting at St. George's and then when I moved to St. Thomas's, because I was building a service that was relatively new, that pool of knowledge that I had when I was treating aneurysms or arterial disease, where I could just phone the mate who was in the office next door to me and we'd do a case together, disappeared. So you had to be on the phone or sending text messages or emailing Peter or Jerry or anybody else to say, listen, I've got this patient, what's going on? And I remember very well, right early on in my career, standing on Westminster Bridge with a patient where things were going horribly wrong, on the phone to Jerry going, mate, what do I do now? You know, where are we? What would you do? How would you bail me out? And, you know, the great thing about Jerry is anything you think you've done, he's probably done as well. And, you know, you can talk through it. The second step is build a team. And that's for two reasons. One is that, you know, success is not a solo pursuit. If you do it by yourself, you're going to get stuffed up. And you're going to get stuffed up for a number of reasons. One is everybody's nervous about change in their practice and they're looking for things to go wrong. And if it goes wrong, they're going to be all over you. Two, it's much more interesting if you do it in a group and you learn from each other and you're growing a practice together. That makes a difference. So the team that I have at St. Thomas's now is really big. And we meet every Tuesday. We discuss all our patients. And We've got a mixed bag of people: interventional radiology, vascular surgery, hematologists, ultrasound technicians, nurse specialists, and other vascular surgeons. And that means that we're learning from each other all the time, but it also means that when patients get into difficulty, or you do find those inevitable problems, we've seen pictures from Rick, who's one of the best there is with a stent migrating. I had a patient and I was deploying a stent where it started to migrate. And without somebody who can come and help you, who understands what you're going through, and you build this together, you can get into trouble. In particular, you can never predict when a disaster is going to happen. I mean, who knows? You're treating a patient. I've done, I don't know how many hundreds of venoplasties now. And I had one patient who arrested on table. And we had the patient, we're doing a venoplasty for in-stent stenosis. I've done that countless times. I've spoken to everybody about it. She arrested on table. We had got her onto ECMO in 15 minutes. Unfortunately, she didn't survive the event. And in the post-mortem, it was because she had clearly had previous PEs that had been asymptomatic and her pulmonary vessels were just knackered. Now, that can happen to anybody at any time. And if you're by yourself, you're very exposed. But having a team around you means that you can defend all of that. And I think that's important. The third step is make sure you've got good pathways. That's pathways not only to get patients to you, but the pathways of managing the patients in the hospital. And don't do this after the event, after you've done 10 people. The normal thing is, once you have your first major complication and there's an SUI in the hospital or a serious investigation about the process, you introduce a pathway to address whatever's just happened. Do those pathways from the very beginning. Make sure you have a pathway for how patients get assessed and seen. So we've introduced pathways in the hospital for acute DVT to make sure that anybody who presents to the hospital with acute DVT gets a full leg duplex scan, and if there's iliofemoral DVT, they get referred to us. So you get the referrals. Make sure you have pathways that cover the treatment of your patients and what you want to happen to them when they go to the ward, so that everybody who's not part of your team, when you're not in the hospital all the time, because you can't be, knows what to do. And that's particularly important when things start to get busier, which they inevitably do. And you might be on holiday or something might happen and a patient comes in and you want the treatment to be the same all the time. And have pathways for what you want to happen in follow-up, what drugs you want them to be on, when you want that to change, how you want the anticoagulation managed, what surveillance you're going to do, all of those things which are pretty readily available now, but put them in place from the very beginning. The next step is obsess about the detail. Don't just think this is easy. You can't just go and shove a catheter in or do an angiojet or whatever, aspirate the clot out and hope that that's going to do. You've got to think about access. Jerry's done some great talks on this. Rick's done some great talks on this. I think IVUS is essential, and you can see here I'm treating an acute DVT patient. And one of the things I use IVUS for example, when you pair that with angiojet, is that angiojet causes renal impairment if you use it in aspiration or thrombectomy mode in flowing blood. On IVUS, you can see where static blood is and where clot is and where flowing blood is. And if you target your angiojet to those points, you minimize all the risks that you have with these patients. You reduce that risk of renal ischemia, you reduce that risk of hemoglobinuria, and you utilize the optimal time on that angiojet to get clot out. Things like profunda inflow. People don't worry about profunda. There's always a bit of clot in the profunda. If you get that out, you massively improve your patency or primary patency rate at the beginning of a procedure. Really think about your anticoagulation. A lot of times I've seen cases go wrong because patients come off the table and they're not anticoagulated. They stop their lysis a couple of hours before when you started the procedure. And those patients will be profoundly prothrombotic. They'll have blocked everything before you even get them back to the ward. Another thing we learned was the old practice in arterial disease was if somebody goes down to the cath lab or the interventional suite for a procedure, they come back to the ward with the sheets in, and those get taken out by the house officer at some point in the afternoon on the ward or in the evening on the ward. In venous patients, that means they're not moving, they're not walking, you don't have stockings on, you don't have flow-trons out, your stent's blocked. And because it's not like an arterial patient where the foot will go white or blue, you don't know that until you scan them. And half the people were not being scanned. So take the sheaths out, take the lines out, get them fully anticoagulated when they leave the table. They leave the table with a stocking and intermittent pneumatic compression on. Go to the ward, have their first dose of anticoagulation before they leave the recovery room. So it's all that sort of detail that just optimizes every step of the procedure. The next thing is follow your patients up. Don't ignore them and let them go. That's one of the biggest lessons we learned from ATRACT is none of the patients were being scanned after their initial procedure. And that's why they were all blocked at 1 year and there was no difference. So follow your patients up because the reintervention rate is mostly in the first 2 to 6 weeks. That's when you're going to pick up technical issues, the mistakes you've made. You're going to find the clotting errors that you've made. You haven't got the anticoagulation optimized. You're going to be able to sort out any inflow issues that you need to sort out. It'll give you the option to do that. We scan our patients day 1, 2 weeks, 6 weeks, and then at broader intervals as they move on from that. And that's allowed us to address a lot of those early errors that we made. And particularly when your learning curve is happening, you will make mistakes. And then repeat it all. So go back to the beginning, go and learn some more, go and spend more time with people, go and find out more, refine your technique, get your protocols better, optimize the process. And, if you get all of this right, and I think we can all safely say in places that do this well, the results are way, way better than any of the trials we've seen. And you will have really grateful patients and you will stop all the problems that people get at the end of it from post-thrombotic syndrome. So the conclusion for this, and hopefully I've been more succinct than Jerry. I don't have soft toys in the back, so I'm not distracted. Success is not a solo pursuit. Ignorance of what you're going to do is not a defense. Just because you've treated arteries doesn't mean you can treat veins. And as in law, don't take ignorance as a defense for this, just rushing in and treating patients. Build really solid foundations. Don't stand still, keep learning about techniques, about devices, about the different treatment options, and make sure the patients are at the center of all of this, that you're getting them right and looking after them, and you will have success in treating acute DVT. Thank you.
That's fantastic, Steve. Really good advice on how to set it all up and what to do. Just one question. You mentioned anticoagulation being extremely important. I know in our institution, we have a lot of problems with anticoagulation and sending the patient down to intensive care. And they're all monitoring APTTs, and APTTs are done. They come back several hours later. They're really not representative of what's happening at the time. And they're acting probably 2 to 4 hours after the APTT drops. And we've found on multiple cases and accounts that we've had rethrombosis because of that.
Yeah.
Have you experienced that? And if you have, how have you dealt with it?
Yeah, so that's where I think the pathways come into it, Steve. We had problems with that in the beginning. So we don't use IV heparin for that reason. It's just a total shambles. So what I will do is on the table, we will measure the ACT, and the patient finishes the procedure with an ACT of over 250. So you bolus them with heparin until you've got them fully anticoagulated. All the sheaths and everything are coming out. You've got a full-length thigh stocking plus RPC device on them when they come off the table. So they move from the table onto the bed, fully anticoagulated, stockings on, intermittent pneumatic compression on. They go to recovery, and in recovery, we give them, within an hour of the procedure, a therapeutic dose, single dose of low molecular weight heparin. So they're fully anticoagulated at that point. And then from the next morning, we have them on BD heparin for the first 2 weeks, so that there's no trough in that time period, because troughs are what destroy you from anticoagulation. So the first day, therapeutic dose, and from the second day, morning, they have split dose B therapeutic.
Say that again, Steve. It just dropped out for a second. Can you say that again, please? That you dropped out.
Sure. Within an hour of the procedure, they get full single dose therapeutic heparin on the day of the treatment. And then from day 2, in the morning and evening, they're on split dose therapeutic low molecular weight heparin. So the morning afterwards, they get a dose, and then in the evening, you continue that for the first 2 weeks, splitting the dose. So we found that the reason for that was if you treat somebody in the morning or afternoon or evening, there was far too much confusion about how to dose the low molecular heparin on that day, and people wouldn't give it because they said, well, they had the last dose 3 hours ago, and then they'd forget to give it later on. So that first day, a single dose of therapeutic low molecular weight heparin, and then they get a split dosing from the following morning. So they start in the morning. So that keeps everybody happy, and nobody was worried about the missing of doses. So that problem you describe is universal.
Yeah, no, absolutely. Absolutely. Rick, what do you do in that circumstance? Have you got a similar situation over there?
I'm an amateur compared to Steve now, because I'm just doing my 5,000 heparins when I start the procedure. And if it's a long procedure, I will do another 5,000, and long procedure might be more than 2 hours, which is actually rare at this moment. And then when, and the patient wakes up, so we try not to do that many on full anesthesia, more sedation. So they're pretty fast again, being able to take medication. And they always go in with full anticoagulation. So Eliquis or Xarelto or whatever. So they just continue to take it with me. And then I've got some kind of, feeling that I started when I got here, because there's another very, very important thing that Steve said. He's got the most perfect team. He's the most perfect interventionist. But I came from Maastricht, and it was also a very, very good team. And not to harm anyone here, but you cannot compare it. So I am not completely on my own. I don't want to say it like that, but I do not have such a strong team. So what I did, therefore, I'm a little bit more scared. And I put, for the first 3 months, I tend to put aspirin, also administer aspirin next to the anticoagulation. So maybe I'm a little bit on the high side, also based upon the information that I got from the US. But that's how I do it right now. So compared to Steve, it's definitely, I do not do ACTs. I do it on experience and feel, which is I agree completely, absolutely the suboptimal way. And I would like.
But you're going in with. Did you say you're going in with patients fully anticoagulated on DOACs?
Yeah.
Yeah. Okay. So you've still got people who have got fully anticoagulated, and they're not really going to drop off like the heparin does. So similar situation.
I think that's right. And I think Phil's asked a question here, Steve, about the benefit of low molecular weight heparin over DOAC. So I think the answer is there's no comparative data that allows us to choose. There is some reasonable data from the hematological literature that a lead-in phase of low molecular weight heparin is beneficial in the study. So in both rivaroxaban and warfarin, there are trials comparing a lead-in phase of low molecular weight heparin over an initial introduction of the DOAC or warfarin from the very beginning. It's only with rivaroxaban, of course. It's Einstein, I think one of the Einstein studies, I forget now which one it is. But there does seem to be a little bit of additional benefit for low molecular weight heparin in the first 2 weeks as a lead-in. And Mark Garcia has spoken about that quite extensively with Access PTS data. There seems to be a benefit from low molecular weight heparin being used in the beginning. So that's why we've gone for a lead-in phase of low molecular weight heparin. So it's not strong, but there is a suggestion that the added anti-inflammatory effects of the heparins are beneficial in that early phase of the DVT treatment. The caveat to that is you've got to be careful of patients over 100 kilos because they do not get into the right range limits. So we test the 10A levels in those patients to make sure that we're dosing them appropriately. So you just want to be careful of your big patients. That's probably more of a problem for us than Australia. Maybe it depends on where you go, I guess. But not what I saw around Sydney, but maybe
certainly not Coogee.
Gold Coast. But the so then we go, and at the moment I think there's no real data between DOACs and warfarin. We tended to use warfarin, but DOACs are probably equally fine.
Okay, Rick, do you have a preference over, say, rivaroxaban versus apixaban, dosing wise? Do you think one's better than the other?
No, I don't dare to tell you actually, because as again, we went with Xarelto in Maastricht, and then I worked with Michael Lichtenberg in Germany, and we both had a feeling that Eliquis would be, you see, less reocclusions. Absolutely no data. So I mean, I should not even tell you, because there's absolutely no background on that. There's no proof whatsoever. I just do it. The only thing that maybe based upon the patient's preferences, when to take it, how many to take a day, do you take it with food? Don't you have to do it with food, etc., etc. All those things might come in an equation, but I don't have any real further important or significant information to share on that subject.
Yeah, Steve,
agree.
I think from our experience, we've discussed this extensively with, I don't know if you know Andy Cohen, who's a vascular medicine specialist, but he's one of the authors on pretty much most of the DOAC trials, and he's in our team. He wasn't on the picture I showed earlier on, but we spent a lot of time discussing this. So rivaroxaban, the dosing curve of rivaroxaban is much more variable than you get with apixaban, because they went for a single dosing drug. So they had to push the levels up to get at a single dose. So you have a much higher peak and a much lower trough than you get with apixaban. And theoretically, troughs are the problem for venous stenting. So apixaban has a flatter dosing curve, so in theory should be better. Yet, other thing that Rick made is a very important point, is that rivaroxaban you have to take with food. And patients forget that. And it's not just a cup of coffee walking out the door in the morning. You have to take it with a full meal. So you find that patients don't do that, and then they fail on rivaroxaban. It's not because the drug isn't working, it's because of how you take it. So apixaban is easier to take for people because there's none of the food interactions, and you get a flatter dose curve. So we've tended towards using apixaban in preference to rivaroxaban for those reasons. But again, there is no comparative data.
No, all anecdotal. What about you, Jonathan? What do you think?
Again, we've relied heavily on our hematologists, who we work closely with through each case, to manage that side of things. I must say some important notes have been made about follow-up, and I must say we're going to adjust our practice here and follow up more closely at day one, and certainly 2 weeks, because we've been pushing it out to 6 weeks, which I think in some cases is too long.
Yeah. I just wanted to say that Jerry O'Sullivan had to run away to a urgent case. So Jerry's left us for now. He apologizes profusely, but he's definitely part of the team. I think what we can take away from that is that the anticoagulation is extremely important. And look, heparin is extremely unreliable, and especially if you're leaving it up to somebody else, you will get the troughs, and you'll have to deal with problems that you probably think that shouldn't have happened in the future. So something to think about for your own protocols. While we've got you here, we did actually put some questions out to the panel, knowing that we were going to have the 3 most important venous people in the world on tonight. And Will Campbell has basically asked a question. If you fail to cross an occluded iliac system, which includes a common femoral vein, external iliac vein, a common iliac vein, apart from having another crack, is there any other place for a venous crossover bypass? Steve, I'll let you kick off.
So I always try at least 2 or 3 times to get through really extensive occlusions before I'd even consider a bypass, because, you know, like all things, there's an element of luck involved in crossing, for sure. I think if you can make, it's like Gary Player said, the more you practice, the luckier you get, but there's still some luck involved in it. So, and one of the other things is when you're doing these chronic cases, if you are doing something and you get into the wrong place and you keep following the same channel, sometimes stopping, coming back 6 weeks later and having go works. These bypasses are very morbid, and the long-term patency is pretty poor. So you've got to be sure you're going down that route before you need to. And I've had a few patients where on the 2nd or 3rd go, we've got across and they've been fine. So I definitely think having another go first is right. If you've then tried a couple of times and you know you're not going to get through, and you've exhausted all options and you've tried all the techniques and you've increased the complexity with I use sharp recanalization techniques, tips, needles, and other things that you can start bringing into it, then a bypass is a reasonable option for very symptomatic patients. Some people at that point say, no, I'm not taking the risk of a bypass, I'll wait, which is fine as well.
What are your thoughts, Rick?
I can try again. So first of all, I'm not a surgeon, so I cannot do the thing. So that's not an option. And furthermore, But
if you were in Maastricht, where you did have that availability,
to be honest, I always come through. So I always get, I have no other way to say it. No, this you can always go through, and you know, you don't need to use sharp needles. I mean, it's an option, but if you, I don't want to be a bitch, but if you don't have the experience to go through an occluded iliac vein, and then revert to a sharp needle. So in Steve's hands, it's all fine. I mean, he knows exactly what he's doing. Plus, he's a surgeon; he can fix everything. But if you do not have so much experience, then why would you go for such a potential disastrous procedure? You know, with a sharp needle and everything. So just try again, and it is absolutely 100% possible. I'm very, very sure about that.
All right.
And there's so
well,
many, many tips we can share maybe next year or whatever. You know, something that maybe is not very much communicated from the other side. It's sometimes way easier, but from the jugular vein, you might slip away. But then use a Oscar sheath, you know, the very expensive sheath, the last resort, but they're very tight, and you can really, you know, pull yourself into that orifice of the left iliac vein, and then go from the other side and have the wires cross and then balloon and everything. So there's so much to say and so many options, and just continue and build your experience, and you know, yeah, try again.
Yep. All right, last wrap-up comments, guys. Do we have any final comments that you would like to tell the audience to give them their best chance in the venous system?
I was just going to say on that last point,
Sorry,
look
Jonathan?
for. Sorry, on that last point, I was just going to say to look for products with a low profile between the wire and the either the catheter or recross balloon or low profile balloons to work your way slowly across these apparently uncrossable lesions. Works really well as well.
Yeah, I think the Cookmaker Triforce system, which is very good for that reason. I think it's very nice, a combination of sort of CXI and stable sheet. So that's a great thing to add if you want to get it. It really does make a difference, and it comes in straight and angled variety, so you can pretty much support anything. No, Steve, I think the point for people is, first of all, just treat these patients. They are treatable, so go for it. Second one is, I think the most important thing is spend time learning. You know, spend time listening to people. Don't go and, you know, this is be humble. Go in there and go, listen, I'm doing this for the first time. It's like trying a new sport. You know, you may be a great athlete. You know, you may be a super athlete like Jerry is. You know, or that was until his hips got replaced and he can't bend anymore. But you know, it doesn't mean if you can hit a driver 300 yards off the driving tee, you can't just go and play baseball, right? So go and learn about it. Spend time learning about it. Get to grips with the background detail, the knowledge. Understand the patients and understand the treatment options, and then you'll get success. If you just charge in there like a South African into a scrum, you're going to be you're going to find yourself knocked out.
Yeah. Thanks, Steve. Rick, what about you? Any final comments or advice for the audience?
I think
the South Africans do.
I think what Steve, hey, the man's back. I think what Steve said is completely true. And, you know, Steve doesn't need any compliments from me, but I think it's fair to say that Steve really started from almost zero, right? And he came and he listened and he took all the people in, and he listened and he learned and he built up a team all by himself. So I in a way got into, you know, in a prepared bed with that sounds weird, with a vascular surgeon, but but I could, you know, I always had the backup, and I think that the way Steve did it, and now, you know, arguably being the best one at the in the world on this issue with the entire team, I think that's really something that you can learn from very, very much, and very humble and very slowly starting and now doing everything on the very highest level of expertise. So that's actually follow Steve in the way that he did it.
Right. We've got Jerry O'Sullivan back now too.
Yeah,
Jerry,
sorry about that, guys. I just I got a phone call that I was supposed to be in another hospital. It was like, ah! Yeah, I agree.
He's already drunk. This was just.
Jerry, have you had anything to drink? No. Jerry, the connection is not very good.
Go on.
I went to Stanford and I learned about Venus. It was already there,
Keep going. We've got you.
Right.
Maybe not. All right.
No.
Oh no, we've got
in the
you.
morning.
Yeah.
No. Okay. I mean, no, I'm quite sober. Okay, sorry. Okay. I apologize. Okay, we'll leave it at that.
Hey, Jerry, we're going to have to stop you because it's there we go.
One man in the bottom of a pool.
And
Okay.
I agree with what Rick DeGraff had to say. I think building it up organically is the job.
Okay. I'll take that as your last comment.
Maybe not. Okay.
Can't stop him now. It's like a fungus.
Okay, we're going to stop there.
Jesus, I'm
All right.
sorry. I'm either here. Yeah.
It's too funny to stop, but I'm going to have to.
Bye. Good. Thank you. Bye-bye.
All right. Look, I'm going to take the screen back and just say thank you to everybody. I'm going to say special thank you to Stephen Black, Rick DeGraff, Jerry O'Sullivan for being involved as our special guests, speakers throughout this entire program. We would like to also thank all of our speakers, Laurencia, Jonathan in particular for being a moderator as well. We've got Iman, Patrice, Ramesh, Phil, Scott, and Patrick, and also Jean Yip Tang from Singapore. Everyone has contributed greatly to the ANZ Virtual Venous Forum, which is usually held up on the Gold Coast once a year. This is our second event. Next year, we plan to have it again. We would like to thank our sponsors, being BD Bard and Philips, who have gone through and provided the platform and the ability for us to get together on many occasions and discuss very complicated questions and come up with some answers which are going to help us in our practice from day to day. So also I would like to thank Alex Hassan, who has been particularly important for putting all of this together. Alex has been behind the scenes, putting it all together. I didn't put that up, by the way.
No, this is my cue, Steve, to say thank you very much from all of us. Very few of us know how much hard work you've put into this whole thing in getting such an excellent set of presenters from across the world together and in order to educate us all, both the audience and each other. Again, on behalf of everybody, the audience and my fellow speakers and co-presenters, and of course, Bard and Phillips, we'd like to say thank you very much. You've done an excellent job. And I look forward to meeting you in person at the next summit.
Thank you very, very, very much. You know, this is something that we're all very passionate about and we enjoy greatly. So it's extremely my pleasure to get together with all of you and discuss it with all of you. I just got to thank you for making it such a good event. So hopefully in 2021, we'll get all together in person, including Stephen, Rick, and Jerry. Come up and see you, Jonathan, up in the Gold Coast, and we'll meet all in person. So again, thank you. One other thing I want to mention is that these forums are recorded. There is a YouTube channel which has been created. So if you have missed something or you want to go through and go through a couple of talks again. It is available. Alex will be sending you through the links. So basically, we should sign off here and say thank you, and meet again next year in 2021.
Thank you, Stephen.
Thank you.
Great stuff.
Thank you, everyone.
Thank you so much, guys.